All right. Welcome. This is important ECG rhythms for nurses. I came up with this idea because a friend who's a labor and delivery nurse asked me to put together a presentation on some important kind of rhythms that nurses need to be aware of. For those of you who don't know, I'm a paramedic. It's my primary credentials. I'm also an educator for scope education, and I have a podcast called Past the Scope. So, welcome. The main objective today is we're going to be talking about some important ECG rhythms that nurses need to be aware of. Not necessarily the treatments for those rhythms. This is just going to be strictly the actual rhythms and some characteristics of them. So, some definitions you need to be aware of. Sinus, when I say sinus, we're talking about a rhythm that's generated in the SA or sinoatrial node, and we'll talk about that in the conduction system in a second. Ventricular rhythm is the impulses generated from the ventricles. A PVC is a premature ventricular contraction. Bigeminy means one PVC every other beat, and ectopy is a disturbance in the cardiac rhythm which causes an extra beat, or PVC or PAC, any of those kind of ectopic beats. All right, so quick anatomy review of the cardiac conduction system. So you have a couple different features I want you to see and just be aware of here. So I said the SA node, the sinoatrial node for sinus rhythm means the rhythm is being generated from here. I'll do a different color here. Okay. So the general conduction system for a normal sinus beat, you have the electricity that's generated within the SA node up here. That signal then fires and goes down what's called these internodal pathways. So the signal can go either way down here or down here. You'll see follow my track in blue. Then you come to the AV node, which is right here, this big yellow spot right here. That's your AV. You can see that right here, atrioventricular, just the spot between the atrium and the ventricles. Your conduction then goes through this. This is the bundle of His, as you can see right here, labeled bundle of His. Then you have your bundle branches. So you have your left bundle branch and your right bundle branch. You can tell which one is which by which ventricle it goes down. So we have your LV, your left ventricle, and your RV. So you can distinguish which bundle branch you're going down if you don't know, like if you don't have the labels there, if you see which ventricle the pathway is going down. And then you also have in the bottom here, you have these Purkinje fibers. These are your terminal fibers. This is where the signal basically terminates and ends, and that's kind of where you get your contraction from. So signal goes SA, AV, bundle of His, and then into the ventricles, generating a contraction. And then we have this bundle right here. This is called Bachmann's bundle. It basically transmits electricity in the signal from the right atrium over to the left atrium. So the left atrium can contract. All right. So some components of the ECG. This is just very, very basic. So you have your P wave, which is right here. And this stands for atrial depolarization or contraction. So without getting too deep into the weeds, you have your action potential, which is how you generate electricity. So you have kind of your phase 0, phase 1, phase 2, 3, phase 4. So basically what's happening with the P wave is you get this kind of contraction. Actually, the P wave is kind of more like this. So you're getting an impulse generation through the atrium, and that's causing this P wave or this first blip, if you will, before the QRS complex. Then you have your QRS complex, which looks at ventricular depolarization and contraction. And then this is when the atrium is repolarizing. You just don't see it because it's like down here, kind of small compared to the QRS. So your Q wave is kind of this first negative deflection. So when I say negative or positive, positive would be above the baseline, negative is below the baseline. And then here is your baseline. Okay. So positive deflection, negative deflection, your negative deflection before the QRS. So it goes below. So you see it goes down, and it goes straight up here. This is your R wave. And then down is your S wave, which is your negative deflection immediately after the R wave. Then you get your ST segment. It's kind of where you would look for STEMIs. You would see kind of like this elevation. You might see depression in the ST segment. We'll go over that a little bit. And then you have your T wave, which is your ventricular repolarization. This is kind of like your phase 3 right here. So this is when your ventricles are repolarizing, getting ready to generate another impulse and can take another impulse as well. And like you see over here, ST segment is kind of like phase 2, where calcium kind of gets influxed. So you have phase 0 to phase 1 is sodium, 2 calcium, 3 potassium primarily, and then 4 is your baseline where everything is kind of at homeostasis. Okay, it's really important you understand kind of at least the basics of your rhythm and the complex itself, because if you don't understand that, then you'll never understand the rhythms and why they look the way they do, and really how to interpret them. So really quick, we're not going to get too deep in the weeds. This is Einthoven's triangle. This is basically where you put your electrodes, your leads for a 3 lead. So as you see over here, you have your left arm, your right arm, your left leg. You might also hear 4 lead. That's just going to be right leg. This is a grounding lead, the right leg. Basically, it doesn't really do much. You don't need it. You actually just need the 3, but it's just a grounding lead if you understand kind of electrical potential and all that stuff. So electricity typically goes from your negative to positive electrode. So you'll get a rhythm generated from negative to positive. You'll see you have lead 1, lead 2, and lead 3. Typically, when we're looking at rhythms, we're going to be looking at lead 2. And the reason being is because you have electricity that's coming down this way from negative to positive. And if we remember back to the conduction cycle, the conduction system, your SA, AV, all your conduction is here. And so lead 2 is going to give you the best look at your overall conduction, which is why we use lead 2 for your rhythm interpretation. It's really important that you get the right leads in the right places. If you get, let's say, if you put your left arm and right arm over here, it's going to mess up your rhythm. And, or if I've seen this too, and I've done this, where maybe you put your right arm for some reason and then your left leg lead up here, you're basically just going to flip your entire complex and your rhythm's going to be off. So it's really important that we maintain this triangle, and you can go limb, 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 or you can go torso. It's really important though, if you're going to do one, you have to do the other. What do I mean by that? So if you do your arms up here on the limbs, you have to do your legs on the limbs. Also, if you do your arm leads on the trunk, so up here, kind of where these diagrams are, you have to also correspond that with your leg leads. So they also have to be kind of on the trunk. You have to maintain Einthoven's triangle in order to get a good picture. It matters less with kind of your rhythms. It matters a lot more when you're taking a 12 lead, because that can mess with your signal and your image. All right, so next we have some rules and steps for rhythm interpretation. This is kind of the easiest way, I think, to go about it. This is how I learned when I was going through paramedic school. It's much easier to break things down and interpret things if you have rules and steps to go by. Same thing as a protocol. It's a lot easier to remember and it's a lot easier to go by. So first I'm going to look at my rate and rhythm. So is it fast, is it slow, or is it normal? So we know normal heart rate is 60 to 100 beats per minute. So fast obviously is going to be greater than 100, slow is going to be less than 60. Pretty self-explanatory. Then your rhythm, so that's your rate. Your rhythm is going to be either regular, regularly irregular, or irregularly irregular. Now I'm going to get kind of into this a little bit when we talk about things like AFib, but this is just going to be kind of your first step. So whenever I ask students to interpret rhythms, it's going to be, okay, what's your rate and rhythm? And then we'll go from there. So then you look at your duration of your QRS. So is it narrow or wide? So basically what I mean by that is we'll go back up to here. So you're measuring from the start of your Q wave, and I'll kind of look into this. It's not exact. It's going to be more exact when you look at a 12 lead. From the start of your Q wave to the end of your S wave, that's going to be your QRS duration and in time. And I'll go into that and how you measure that in a minute. So narrow or wide. Then you're looking at your P waves. Remember, that's that first blip for the QRS. Is it present? Okay. Is there a P wave or is there not one? And then is it upright or inverted? Again, upright would mean above the baseline. Inverted is below the baseline. So you're looking at that. Is there a P wave for every QRS? So do you have, you come here, you have your P wave, your QRS, and your T wave. And then do you have another P wave before your QRS? It's bad drawing, but basically, do you have a P wave before every QRS? If you don't, or if they're kind of mismatched, then that's a whole different rhythm that gets into blocks and stuff, which we'll kind of touch on. And then any ectopy, remember what I said earlier, ectopy is kind of abnormal rhythms and abnormal electrical impulses. So things like PVCs, PACs, and we'll kind of talk about that as well. So these are your basic rules and steps for rhythm interpretation. If you go by this, you can interpret basically any rhythm if you stick to these rules and go down this. All right, so when I said we're measuring kind of the duration, this is what I mean. So when we look at this, this is more important when you're looking at actual paper. It's harder to do on a screen, which is most of the time what the nurses are going to be looking at is the screen. The paper is needed to truly measure. So when we look at this, we think of time and distance between different structures, okay? So when we look at the paper here, you'll see, and I'll refer to this, these are little boxes, and then your big boxes are this entire thing with the more bold lines. So the little boxes here are 1 millimeter in duration, and then the big boxes are 5 millimeters. So when you're counting, you can easily distinguish this by, okay, it goes one big box that's at least 5 millimeters. It goes at least two big boxes, 10 millimeters, but then you might have to break it down individually to 1 millimeter blocks. And then when we look at time, how much time is elapsing, we have one small box here is going to be 40 milliseconds of time, and then 200 milliseconds of time is one big box. So that's going to be important when we're talking about the width of like the QRS. So if you say the QRS is 0.12 or 120 milliseconds, so 0.20 is going to be 0.20 seconds. That's how much time the impulse is taking. And then your paper speed should be 25 millimeters, which isn't truly important for right now. When we talk about the distance, this diagram's kind of misleading. So distance is going to be in this axis. I think it's the y-axis. And then your time is going to be in your x-axis. So when we look at this 10 millimeters, right? So you're measuring in millimeters tall. So this would be 5 millimeters. This would be another 5 millimeters. So the two of these combined are 10 millimeters. And so you're going to be basically counting, and this really comes into play when you're talking about like ST segments, like I was saying, like ST elevation and depression. Not super, super important, but definitely something to be aware of. Sorry, I keep drawing random lines. I'm doing this not on like good notes or anything, so I have to use both fingers to scroll and kind of drawing random lines, but that's okay. All right. So we talked about, you know, the measurements, what they mean. Now we're going to talk about counting the rate. This seems it can seem a little bit daunting, but I promise it's easier than you think. So there are really two common methods for counting your rate. You have your box method and then your counting method. I personally use the box method. I think this is the easiest, particularly if you don't have a full 6 second rhythm strip. Because with the counting method down here, and you'll see that you need an actual rhythm strip, like a 6 second strip. That's great. But if you don't have that, if you only have one or two complexes, let's say on a 12 lead, it's really important to be able to count that. So that's why personally use the box method. So with the box method, you're measuring the R to R interval. What do I mean by that? So we talked about, so this is your R wave, right? This is your R waves. Your R to R interval is the distance between your R waves, the peak of your R waves to the top. That's your R to R. That's what we use when we're counting rate. Realistically, that's what the machine, the monitor is using to count rate. So when we do this, we take 300 and divide the number of big boxes. So I said the big boxes are these kind of more outlined boxes right here. You're taking the number of big boxes between the R waves and you're dividing that by 300 to get your rate. And like I said, the benefit of this is you're able to determine the rate without a 6 second strip. So if we look at the diagram here, so you have one big box here. That's going to be 300 beats per minute. That's really, really fast. So if you only have one big box between, that's a super fast rhythm. And then it breaks down in a very uniform fashion. So for two big boxes, obviously it's 150 beats. Three big boxes is 100, 75, 60, and then it goes on and on and on until you get to zero. Um, Again, really easy. The counting method is similar. You need a 6 second strip. So this is considered a 6 second rhythm strip right here. And then you would basically count the number of QRS complexes in that 6 second rhythm strip and divide and multiply by 10. So in this case right here, if I were to have, 1, 2, 3, 4, 5, 6, I would have 6 QRSs in that 6 second strip. I would multiply that by 10. I have 60 beats per minute. Either way is fine. I just prefer the box method because I think it's much easier to determine a rate even without an actual rhythm strip. All right. Now we got the kind of the technical stuff out of the way. That's really important for you to understand before we get into this because if you don't understand kind of like the basics similar to A&P, if you don't understand the basics of anatomy and physiology, it's really difficult to understand the actual disease processes. So it's sinus rhythm. So I said sinus, the rhythm is being generated from the SA node, excuse me. You might hear this called normal sinus rhythm too. It's normal sinus rhythm is kind of a misnomer a little bit because it can be an abnormal rhythm, but it can also be sinus rhythm. Okay, so a sinus rhythm basically means you have a P before every QRS. So I have a P wave before every single QRS complex. That's basically it for sinus rhythm. Is if you have an upright P wave before every QRS complex, that's considered a sinus rhythm. Really, technically, you have to have an upright P wave before the QRS for it to be a sinus rhythm because you can have a P wave before every QRS, but the P wave can be like inverted, and that's not a sinus rhythm. That's a different rhythm entirely. Um, so this is a normal sinus rhythm. This is the rhythm and the regularity. This would be a regular rhythm. And you can tell that it's harder to tell. Like this one's pretty easy to tell. They're all like kind of a uniform distance apart. It's harder to tell when there's small variations. A way to tell that, and this is going to be like if you have paper, to take a piece of paper and start with your first couple, make a mark here, and then move the piece of paper down the rhythm. And if all of these kind of match up with those two lines, that's a regular rhythm. And then you have small irregularities. So let's say, these two are the same distance apart right here. And then let's say this rhythm, this R wave is right here. So that's going to be a shorter distance between the two. That's going to be a regularly irregular rhythm. So just a very slight irregularity, but otherwise that is a normal rhythm. And that's something called like a sinus arrhythmia. It can also be PACs, but it's not, that's a little bit too in depth. So this is just going to be your sinus rhythm. And this is going to be a rate. And we'll kind of break it down here. Try to start with a big line. So right here, so we see big boxes here. Kind of more difficult to see. These ones are not, this diagram's not as clear of the big boxes. Let me get my eraser. So the big boxes are not nearly as clear here, but let's say you have a big box right, I'm gonna say right here, right here, right here. And so this can be a little bit different, and then here. So this is gonna be like a rate of like 75. Okay. Sometimes they're not as bold lines, like you'll see here, 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 here. So you got to kind of look sometimes. So that's a rate of 75. This can be a sinus rhythm, what would normally be called a normal sinus rhythm. And then sinus bradycardia. So again, this is a sinus rhythm. So upright P wave before the QRSs. This is just a slower rate than 60, obviously. So let's say you have 300, 150, 100, 75, 60, 50, 40. So this is about a rate of 40, right? So 40 beats per minute, that's less than 60, that's going to be bradycardia. So this is your sinus bradycardia, and this is going to be a regular rhythm. Again, an example of a regular rhythm. Then you have your sinus tachycardia, again, kind of beating a dead horse. You have an upright P wave before every QRS complex. There's your sinus rhythm. And then let's look at your rate. So your rate you have, that'd be 300, 150. That's about a rate of, it's probably about 120. It's, again, not an exact rate. You kind of have to guesstimate when it's kind of between the big boxes. That's about a rate of 120. And this is regular. Again, if you looked at this, you would see that there is a good regularity. So this is a regular sinus tachycardia. This is a good example too of what I said with the ST segments. So the ST segments should be on the baseline. So this is your baseline. If you draw a line across that, this is your ST segment right here. This is depressed. So this is ST depression. And if you measure kind of the distance, you'll see that's 1 millimeter of ST depression. This in and of itself doesn't necessarily mean they're having some cardiac event. This is really common in rate related. So like if the rate is 180 and the heart doesn't have time to fill, it can have some ischemic changes. That's called demand or rate related ischemia, but that's a little bit deeper into the weeds. That's more on the 12 lead stuff. Don't immediately freak out if you see this, but that's your sinus tachycardia. While we're talking about that, sinus tachycardia does not need rate control. Okay, this is in a deeper discussion, but in general, sinus tachycardia is compensatory for something else, right? So if you have a sinus tachycardia, you need to be looking for the cause, whether it's sepsis, dehydration, they had too much caffeine, cocaine, etc. They don't need rate control. They need to treat the underlying symptom, whether that's fluids or benzos, whatever you need. Some of the other rhythms we'll get into that need a little bit different treatment. Okay. All right, so the next one, this is a really common one, particularly in the older population, atrial fibrillation. So basically what's happening is the atria on top of the heart. So again, terrible drawing. You should have normal contraction, normal squeeze, and a normal rhythm. These atria are kind of shaking, fluttering, and so you're not getting good atrial squeeze out of this, so you don't have P waves. This technical definition of this rhythm is a irregular rhythm without discernible P waves, so that basically you cannot determine P waves in here, whether there are none or you just can't see them. Maybe it's too fast. Okay, so you see there are no P waves before the QRSs, and you have an irregular rhythm. What the heck does that mean? Right, so I said earlier kind of a regularly irregular rhythm. you would have, a baseline rhythm is normal and that is regular, and then you have maybe slight irregularities, slight early beats, late beats, whatever. This one, if you notice, almost every Q or every R to R interval is a different distance between the two. Okay, some of them are more regular, but then you have, a lot wider here, a lot shorter here. This one's a lot wider. So almost every single beat is in the R to R interval is different. That's going to be irregularly irregular. Now, a lot of patients have AFib at baseline, so you can get an AFib with a rate of like, 60 to 90. That's not a problem. That's just their underlying rhythm. This is going to be what's called AFib with rapid ventricular response or AFib with RVR. You'll hear that term a lot, or rapid AFib. You might hear in different parts of the country. Up north, that's kind of a lot more acceptable. But usually it's AFib with RVR, and that's just rapid ventricular response. Means there's a tachycardic rate along with that. AFib is a little bit different. You can have this is a primarily rate related problem, or this can be, again, like sinus tachycardia, compensatory. That's a whole different discussion. It's probably never a bad idea to like start with a fluid bolus. I often do that. I rarely ever go straight to like metoprolol or anything like that. This is actually my case. This is a call that I had. I think this person had a rate. Yeah, they had a rate of like 240, 220 at most. You see like kind of the lowest rhythm we have here is 150. Yeah, so this is a patient that I had. So there's your AFib. I hope that makes sense. Like it's very brief, but this is your cardioverted AFib. I thought this was kind of cool to throw in there. Again, this is my call. This is a patient that I ended up cardioverting out of AFib because I believe this patient had a pressure of 70 over 30. Was alert and oriented, but had a pressure of 70 over 30 with a AFib with RVR at like 200 to 220 ish, a little bit, maybe a little bit faster, maybe a little bit slower. I can't remember exactly, but that's unstable tachycardia. That's likely rate related hypotension. So I gave her a little bit of Versed and cardioverted, and then you see here, this is your shock, your synchronized cardioversion. These are the little triangles here are synchronized. We use LifePak monitors. You'll see that on pretty much every monitor. And then I converted her into a sinus rhythm. So this is like a sinus arrhythmia. So you have P waves, P waves, P waves, P waves. So I converted her into a sinus rhythm at a normal rate, a sinus arrhythmia. So I just thought that was kind of cool to throw in there what a cardioversion kind of looks like on the rhythm. So next we have our atrial flutter. So this is a little bit different than fib. This can be regular. A lot of times it is regular. So atrial flutter, same thing. It's an atrial rhythm. The rhythm is generated within the atria. Just a different kind of area of the atrium. So if we look, let's say the same thing with AFib. So instead of generating, let's say up here in the SA node, which would generate a sinus rhythm, let's say the rhythm is generated down here at this foci, this different electrical area that's generating that impulse. If it's not from the SA node, it's not going to generate a P wave. So that's the big differentiation between the two. So that you just get some like weird electrical rhythm, which is not generating a P wave. Same thing with the atrial flutter. Now, this is a little bit different. This rhythm may be coming from the SA node, but you also usually have what's called a reentry circuit. So basically within the right atrium itself, it basically goes in a loop, and then you have just spontaneous firing and all that stuff. So you have just a rapid rate, and you'll see that with this rhythm. So basically atrial flutter, you have these flutter or sawtooth looking waves between the QRS complexes. So again, you have your QRS. There is your flutter waves, and you'll see that doesn't look like a P wave, doesn't really look like a T wave. There's no defined thing there. This one is regular. So in order to count the rate, you can count the rate based off of R to R intervals. More often than not, you'll hear it as a ratio. So basically, you'll see you count the flutter waves. So we have 1, 2, 3, 4. So this is going to be a 4-to-1 a flutter or AFL. You'll see sometimes. So basically, that is, you can say the rate, but people are typically going to know, hey, this is a 4-to-1 ratio, and that correlates with the rhythm. So this is a normal rhythm, right? So we have, let's say, 300, 150, 100, 75. So again, this is a normal rhythm, and you can kind of correlate. 4-to-1 means, okay, probably it's around 75. If it's 3-to-1, it's probably 100. If it's 2-to-1, it's going to be 150, and so on and so on. A 1-to-1 would be 300. Okay, so this one is regular. Okay, that's an example of that. Then this one down here is an example of a slow A flutter. So this one is regular as well. And you have different, I think I have, maybe I don't have irregulars. So if you have different rates of these, so let's say this one is 4-to-1, let's say this one is 2-to-1, this one is a 3-to-1, this one's a 4-to-1, that's basically a varying interval. Yeah, so basically that's a variable interval, and that's kind of like AFib, you kind of give a range. Variable conduction is a term you'll hear a lot. So again, we have, QRS, and then we have a lot more flutter waves. So we have 1, 2, 3, 4, 5, 6, 7, 8. So 8 in between. That's a lot slower of a rate, right? So you have 300, 150, 100, 75, 60, 50, 40, 30. Like this is a really, really slow rate right now. This is a rate where I'm definitely going to be doing something for this person to get their heart rate up. Okay. So we talked about the atrial rhythms. Next thing, I'm not going to get into this too much. I have a podcast on this particular rhythm on Past the Scope. This is the SVT rhythm. I highly recommend, if you want to know more, listen to that episode. This is a shameless plug, but that episode goes a lot more in depth on this rhythm right here, SVT, or supraventricular tachycardia. So supraventricular tachycardia basically is an umbrella term. It encompasses things like AFib, but if you say SVT, this is the rhythm people are going to think about. So if we break the word down, supra means above, ventricular, above the ventricles. So this is a rhythm that is generated above the ventricles, which is why you can see it. It encompasses things like sinus tach, AFib, etc. And then tachycardia, obviously we know what that rate. This is a rhythm specifically called AVNRT. Again, that's a little bit more technical. If you say SVT, people are going to know what you're talking about, and it's this rhythm. So technical definition, you have a rhythm. This is a regular rhythm. So this is regular without discernible P waves. So like AFib, you don't have these discernible P waves. And this is a rate that's going to be greater than 150 beats per minute. Now, just because their rate is 160 doesn't mean they're an SVT. Technically, like this particular rhythm, that's something that a lot of people make a mistake on. But this is the textbook definition of SVT. This is like where you'll see people given adenosine for and those kind of things. People can have paroxysmal or PSVTs. Basically, they vagal themselves down, or they get meds and they fix themselves. This is a pretty common rhythm. This is a really common rhythm in younger folks. Not as much in older people. You can have it in older people. Typically, they're going to have AFib, but really common in younger people. Again, just very brief overview. I'm not going to get into the weeds of this. If you want more information, I highly recommend going to listen to the podcast episode that I made on this. It's on YouTube as well if you want to see that. We saw those ST depression, same thing here. This is the rate-related ischemia because the rate is a lot higher. So this rate is about like 170, 180 as you go between the two. All right. Next, we're going to talk about some of the ectopy stuff. So sinus rhythm with bigeminy PVCs. So we know the sinus rhythm. So you have upright P wave, upright P wave. So you can have that underlying sinus rhythm. These big complexes are PVCs, or premature ventricular contractions. So premature meaning they come kind of before the normal electrical impulse. and they are generated from the ventricles. So they're generated from that ventricular myocardium tissue. And we didn't talk about this with the electrical conduction. Electrical conduction through the normal pathway is fast. Okay, that's like a super highway for electricity. And we talked about the duration of the QRS is a measure of time. So if it doesn't take a lot of time, it's going to be narrow. If it takes a lot more time, it's going to be wide. So you see, this is a perfect example of a wide QRS compared to this would be a narrow QRS right here. So you see the difference, which means this is generated in the ventricles because the ventricles have what's called cell-to-cell conduction, which is going to take a lot longer of a time. If you think about, it's going to take me a lot longer to go back roads and side roads than it is for me to get on the interstate and travel. It's kind of the same thing when it comes to conduction. Okay, so you have these big PVCs. This is another example of a PVC down here. They can look a little bit different. You get what's called unifocal or multifocal. These are both unifocal, so basically like one morphology. You can get multiple that you can get a rhythm that has like one of these and then one of these and then a little bit different. That's a little bit more in depth. And then we talk about, like I said, bigeminy. So bigeminy is a PVC between every single beat. So the typical thing is you have, a normal QRS PVC, normal QRS PVC, normal QRS PVC. That's bigeminy. Okay, so every other beat is a PVC. Trigeminy, you'll hear too. That is every third beat is a PVC. So you have like two normal QRSs and then a big PVC. And then you have a little bit more like I think I bring it in here later, but like couplets and triplets, that's just PVCs in a row. And then VTAC is, and I'll talk about that, is like basically a bunch of PVCs in a row. Okay, so another really cool thing that I wanted to include in here because it's very interesting. So you can have what's called perfusing and non-perfusing PVCs. Basically, does that PVC generate contraction? Does it generate some bit of outflow? And you'll see that this is the pulse ox waveform right here, the pleth. So should normally, as you see here, you kind of have this normal pulse ox here, and it should go down and then come back up if this PVC is perfusing. So this is a non-perfusing. You can tell by manually palpating their pulse, and if you see a rhythm on the monitor and there's no pulse associated with that, that's non-perfusing. But another way you can do that is if you have a good pulse ox tracing. If you just have a flat line, you can't really use that. But this is another way to do that. So like this PVC right here may be perfusing because you have a little bit of a change. But if it's just kind of a flat line, like you'll see right here, that's probably not a perfusing PVC. Not a huge deal. It just means like if this underlying rate is 70, but with the PVC, the rate is a lot slower, and it's like 30 or 40. Maybe they're not getting as much like perfusion and all that stuff, and that goes into a little bit more in depth. But PVCs, not a huge deal. A lot of people have them. It's when they start having a lot, like bigeminy, that doesn't necessarily need treatment. A lot of times, these people just need a little bit of fluids because they're dehydrated, or they need some supplemental O2 because they're a little bit ischemic in some ways because they're not getting enough oxygen. Usually, if you give them fluids or oxygen, that goes away. This is really common associated with palpitations. I get them like when I drink too much caffeine or what have you. Some people, too much caffeine, take Adderall, that kind of stuff. You can get palpitations. That's usually from PVCs because it's just that electrical impulse is being generated because the heart's a little bit irritated. Next one is called a junctional rhythm. So junctional basically means that you have a rhythm that's being generated from the AV junction. So what I mean by the AV junction, let me see if I can pull this up here. So the AV junction is this piece right here. So between the AV node and the ventricles, this is your AV junction. So basically the junctional rhythm is a rhythm that's being generated in this area of the heart. If that makes sense. Instead of up here like an atrial rhythm, this is neither an atrial nor a ventricular rhythm. This is a junctional rhythm because the rhythm comes from down there. Okay. Where was I? Right there. Okay. All right. So this is defined as a rhythm that does not have a PVC, or it can have an inverted or downright PVC. So if you have like a PVC right here, right before with a short PR, PR is the distance between the beginning of the P wave and the R wave, but which is right here. So short PR with an inverted P wave or no P wave at all is your junctional rhythm. So you see, you don't have any P wave right here. You have your QRS, and then you have a big T wave right there. These are typically going to be, you can have like accelerated junctional where they're at a normal rate. You can also have junctional tachycardias. This is going to be what's called a junctional escape rhythm because we know that the SA node has a conduction rate of 60 to 100. The AV node has a conduction rate of 40 to 60, and then the ventricles have a conduction rate of 20 to 40 beats per minute. Excuse me. So if it's a lot slower of a rate, right? So you get like, let's count. So you have 300, 150, 175, 60, 50, 40, 30, 20. Like this is a really, really slow rate. And this is it's basically the conduction system of like the SA node, the AV node is basically knocked out for whatever reason. And so the heart says, hey, I don't like this. I'm going to have this backup rhythm that this one's a little bit wide. So you can have this, typically these are wide at this slow rate because it's being generated from the ventricles. That's when you kind of get of a more ventricular rhythm. So that's your junctional rhythm. Some people have this frequently. Some people like kind of live in a junctional rhythm. Some people don't. Then you have your idioventricular rhythm. So this is essentially a ventricular rhythm. So it's wide and it's at a really slow rate. So a rate of like 20, which this one's a really slow rate. And you see the QRS is nice and wide. This is really common in patients with severe hyperkalemia or patients who maybe they had a STEMI, they just got cathed, and it's called a reperfusion rhythm. You can see the same thing post cardiac arrest if you have gotten return of spontaneous circulation on a cardiac arrest and you see this big, wide, slow rhythm. That's likely just a reperfusion rhythm, which is this idioventricular rhythm. So it's just a rhythm that's a really slow rate and it's wide. In very simple terms, a slow, wide rhythm is idioventricular. Next, we're going to talk about blocks. So AV blocks. So basically, this is saying that at the AV node, there is something going on that's kind of blocking conduction going through it. So you have normal atrial rates, so normal SA node firing, but for some reason there is something like a dam or the way I like to think about this, depending on the AV block, it's either like a road closure or it's, hey, there's a flagger ahead and we only have one lane open at a time. So it's going to be a lot slower moving. So there's different types of AV blocks. The most concerning one that you really need to be worried about is this third degree or complete AV block, basically meaning there's a road closure at the AV node. So you have your P waves, what they're called marching out. So the P waves are at like a normal 60 to 100 rate. Your SA node is still healthy and functioning, but you just have a problem with your AV node. So this is complete dissociation between the atria and the ventricles. So you have your normal P waves, your normal atrial rate, and then you have this ventricular escape rate with the QRS complexes, which is going to be a lot slower. Really common. So with this, you'll get P waves that kind of don't align. So right, your differing PR intervals. So like here to here is a lot longer than here to here. Same thing here to here. So this is textbook for a complete heart block. And if you don't get it right, if you say it's a complete heart block when it's like a second degree type 2 heart block, it's not a big deal. This is a patient that they likely are going to get a pacemaker. Potentially you're going to need something like a pace, like to be transcutaneous paced. Atropine is a common med for bradycardia. It does not work on these. And that's, if you take ACLS, you'll get more into that. Okay. Really, really dangerous rhythm. People can be completely stable on this and people like sometimes freak out. I've seen, a grandma sitting in a third degree heart block in the 30s, just chilling out on the stretcher. And then I've had people that have died, have coded from this because their rate is so slow and we didn't get to it in time. Okay. There are a lot of reasons for a complete heart block. That's a whole other video. All right, a lot of information so far. Take a second, take a breath, reset, pause if you need to, go do something else because we're about to get into like the cardiac arrest rhythms. If you take ACLS or anything like this, you'll know all these things. There's just kind of a general overview of your different cardiac arrest rhythms. So first, most common one, most everyone knows asystole. So it's a flat line. It can be a little bit wavy like this, but the gist is it's a flat line because there is no electrical conduction going through the heart. None at all. You don't even get like P waves, anything. Asystolic, you have no cardiac activity at all. Okay. Very, very simple. Now, versus if the patient maybe gets disconnected from the monitor, you won't see a flat line. You'll see like dots on the monitor like that. That just means the patient got disconnected. But if you see this flat line, that's a problem. That's a big problem. Then you have something called ventricular standstill, and this is exactly what it says, right? The ventricles are not contracting at all. So you get these P waves without QRS complexes. So basically the atria is still working. The ventricle's just not working at all, whether it's because of a complete heart block or something else that maybe they had a big MI and their ventricle just got knocked out and they're getting no ventricular contraction. This is the same as asystole. Okay, this is treated the exact same as asystole because you're getting no ventricular contraction, no ventricular activity. Then you have ventricular fibrillation. You'll hear this as VFib or VF is the common shorthand for this. So this is basically the ventricles are quivering and fibrillating similar to like AFib, but it's just the ventricles. This is a lethal rhythm. This is non-life sustaining. I don't think I've ever seen a patient be conscious with VF. Maybe like an LVAD patient, but typically they're not conscious at all. So this is not checking for a pulse. This is you see VF, you immediately jump on their chest, start doing chest compressions, and they need to be shocked. Okay, so you get these. This is called fine VF, and this is coarse VF. Basically, what that means is these little fibrillation waves. Do they look kind of like really small squiggles, or these big squiggles here? Those are technical terms, by the way, squiggles. Um, is it fine or coarse? Does it really matter? No, it's going to be treated the same way. This patient needs to be shocked, but it's kind of a interesting thing to know. Okay. And we're not going to get into like the treatment of these because that goes into like ACLS. This presentation is just about rhythms and rhythm interpretation. That's all it is. Okay. So your next rhythm is ventricular tachycardia, VTAC or VT. You'll hear it called. This one is a little bit different because you want to check for a pulse with this because patients can have a pulse with this. And the treatment's a little bit different. If they have a pulse, they're going to get synchronized cardioversion, where like the little triangles that you saw in the AFib example. And if they don't have a pulse, you're going to treat that just the same as VFib, and you're going to just defib them. So what this is, it's a ventricular rhythm. So the QRS is going to be wide, and it's going to be fast. So typically this is going to be rates greater than 130, because people have called like an accelerated idioventricular, so like a wide rhythm at like 110. Technically, it's ventricular tachycardia, but it's not VTAC, and it should be treated a little bit differently. This is going to be really fast. So these are rates. You see here, like this rate is, these are actually the T waves, but this is a rate of like 300 right here. So really, really fast, wide. The ventricles are only working and the heart rate's going so fast, it cannot perfuse itself. So this is a lethal rhythm. This won't sustain for very long. So you need to jump on this, whether it's defib, cardioversion, or antiarrhythmics like amiodarone, lidocaine, those kind of things. You can have different morphologies of the QRS, different basically how they're formed. So these are inverted, downright. These are upright. So either way, wide, really fast. It's VTAC until proven otherwise, and it needs to be treated as such. Because again, these are not sustainable rhythms. These patients will die if they're not taken care of. Getting towards the end here. We're getting to it. This next one, this is torsades de pointe. It's French. You'll see this TDP. This is a type of polymorphic VTAC. So it's a ventricular tachycardia. What I mean by polymorphic, this is an example of monomorphic. Basically, all of these complexes look the exact same. So one morphology, one shape. This if this word breaks down like one shape, so you have all the complexes have a similar shape. This polymorphic, so multiple shapes, multiple forms. So you have this like regular rhythm, and then you have this wide rhythm that is different morphology. So you see it kind of changes. This is a little bit less drastic, but it changes up here. The hallmark of this is what the torsades name translates to in French. It's twisting at the points. So you'll see a lot of times this is a little bit less drastic, but a lot of times you'll see one morphology here and then it gets down here and it almost twists and then you'll get like maybe downright complexes. This one's pretty self-explanatory. Like it gets bigger, smaller, and then bigger again. That's textbook for that. Little things you don't necessarily need to know. Technically, the definition of torsades is it has to have a prolonged QT. So you have your Q wave, your T wave to the end of the T wave. It has to have a prolonged QT or QTC in order to be called torsades. Otherwise, it's just a polymorphic VTAC. Most people are just going to call this torsades regardless. But in order to technically, like your textbook definition is you have to have a prolonged QT. So like if you don't have a EKG like this, where you can see the QT interval, technically it's just a polymorphic VTAC. They're treated the same. They're given MAG, and these patients are always going to be defibbed. Okay, another very lethal rhythm. Almost done. We got one more actually. So this I thought was really cool. This is an example of a 12 lead from an inferior STEMI. So you have, not that you need to necessarily know this, but you have ST segment elevation in 2, 3, and AVF with depression. Here's a really good example of depression in your lateral lead. So this is an inferior STEMI, big old heart attack. And this is one I found kind of on the internet. This is really cool. So you have, it doesn't happen often, but you'll get this STEMI. Then you have this big PVC right here, another PVC, and then the patient goes right into VFib. So you see this in real time. And this is, I just thought this was really cool. It kind of gives you an example of multiple different rhythms, kind of an example of a 12 lead, but not really. So inferior STEMI into VFib. I think that's just, it's a really cool thing to see because it doesn't happen often. If you want some further reading, the company I work for, Scope Education, we have a ECG masterclass. It can give you CEU hours. It's a really good course. Even if I didn't work for Scope, it's a really, really good course. I highly recommend it if you want to know more. We also have this 12 lead Decipher system. This is a community that we have for discussing EKGs and cardiology and different things. There is a discount code here, ECGRN, at checkout. That'll give you a discount. I can't remember exactly what the discount is, but there is a discount code there. It gives you access to lectures, a fillable workbook, and access to the community. So lots of great content there. And then go follow us on all of our platforms. Again, this is the podcast that I talked about, Past the Scope. We're also on Instagram, Facebook, YouTube, and then this is our website where you can get access to cool swag, our courses, and everything else that we have. Okay. That's it. Thanks for joining me. And if you have any further content suggestions or anything, please give me a shout. Thanks.